It's my honor to be here, to report our AURORA study. Hey, Matthias, this is Dr. Song. Yeah, it's a long time haven't seen you.
Hi, Song.
Yeah. So we all know, AOT accreditation in China is a little bit different, from the European heart survey, because you can see from the China DVD study led by Professor Wu in Fuai Hospital, we can see the residence patient, the AR rate is 15%, right? It's almost double the rates of aortic stenosis. Yeah. And from the European heart survey, we can see the aortic regurgitation is 13%, almost the same. Almost 1/3, of aortic stenosis. So I think we actually, in the outpatient, we can see more aortic regurgitation than aortic stenosis in China. And from the guideline, no matter 2021 for the ESA guideline and 2020 from AHA guideline, we can see, TAVR for the pure AR patient is very cautious. And there's no recommendation, from the AHA-ACC guidelines, actually. But from China, we have the transapical device like G12 was approved by NMPA in 2017. So we recommended TAVR can be performed for AR in experienced centers, and also we need to choose actually the right patients and also experienced operators, if the anatomy is good. But still, until now, we don't know, which anatomy is good, for the candidate of pure AR for TAVR. I'm sorry, get a bad cold. So in the early years of AR in China, the transapical TAVR using G12 for pure AR can reach, I think, 91.6% device success. But this access, I think, may be much more invasive. So it cannot, be done without the surgeons. So transfemoral TAVR was less invasive, but cannot reach high device success in the pure AR patients. Actually, since we have the multiplanar measurement to check, where is the anchoring area and where the sealing area, for the TAVR in China. And we are more and more clear, to know, where is main anchoring points. So from here, you can know we divided, from the ascending aorta to the LVOT to three areas. So one area we can see is from this annulus level, the yellow line. We measured every 2 millimeters above the annulus. We can see from 0 to 10 millimeters. I think this area is annulus level. And from 0 to 6 below the annulus, I think this is LVOT level. So this is a two area to anchoring the TAVR valve. And also the third area is ascending aorta. Especially we divided maybe from the STG and to the 40 meters above the annulus. So this is the third area. So this is main points, for our new classification. So we have annulus level, we have LVOT level, and ascending aorta level. So if all the TAVR valves can anchor, the main area is the annulus level, and the assistant area is LVOT and ascending aorta level. If all the area can be oversizing maybe 10%, So we think, the valve can be very well located, on the native valve. And type 2 is annulus level and ascending aorta level. And type 3 is annulus level and alveoli level. All the area is 10% oversizing. If there is no anchoring or only anchoring maybe on one area, we think this is type 4. And type 1 to type 3 can be candidates for TAVR. So this is a pre-study, and we use the first generation without recapturable system. We included 32 patients, and type 1 is 13 patients, and type 2 is 11 patients, and type 3 is 8 patients. So all patients have 100% procedure successful rates. And the device success rate is 93.8. We have 2 valve involved and higher rates of permanent pacemaker implantation. This is because, we used the first generation of the valve. We worried about, the valve jumping to the ascending aorta. So actually, we started a little bit lower than right now. So the depth of this valve is, you can see here, the venous A valve, its implantation depth is almost 12, and the vita flow valve is almost 8. So this is the reason, I think, why we have such a higher pacemaker rates. So, and we actually used 2 valves, venous A valve and vita flow valve. From venous A valve, this is more like a tapered shaped frame, and for the vita flow valve, this is a tubular shaped frame. So I think this makes a difference. You can see from the vita flow valve, the device successful rate is 100%. Yeah, and almost no delayed, malposition. Yeah, this is because this is more tubular shaped. So you can see the compression is almost horizontal, to the frame. So I think this is easier to anchoring, to the native valve. After this study, and we actually discussed with Nico Piazza and also Thomas Modin and Hassan Jilawi, and we finally, they suggest us to start, the AURORA study in China, and we included, we're supposed to include maybe to include 100 patients with pure AR and without any calcification. And we divided the patients, to type 1, 2, 3, 4, and 1, 2, 3 is good candidates for the TAVR procedure. Yeah. And we have 19 centers. Until now, actually last year I reported the result to London Valve. And this year we actually included almost 70 patients. The mean age is 77, and we have different types, for type 1, 2, 3. Most of the patients is type 3. Yeah. And all patients were performed from the transfemoral approach. And we have also annulus diameter of more than 28 patients. This is 12%. And the main annulus diameter is 26.5. So you can see the aortic regurgitation for the annulus diameter is almost over 26. This is oversizing index. You can see annulus level mean is 18%, alveoli level is 13%, and ascending aorta level is 13%. Because most centers, they don't have experience, to do the vata flow valve to treat aortic regurgitation. So I think this is because of the learning curve. So the technical success rate is only 91.3%. But I think the good point is the new pacemaker, permanent pacemaker rate is only 5.8. This is because, for this study, we use a second generation of vata flow valve. So we can recapture the valve when we find, the valve is not good it's not in a good position. So almost every procedure we can put it, to be a very high position. And we don't have patients with moderate or more parallel leak. And also we have another borderline group also. This group is oversizing is less than 10, but I think is more than 8%. So we tried, to explosive, if this kind of if the patient oversizing is less than 10, is good or not. Now we can show some cases to you. This is a 74 years old patient. Now you can see the leaflet is thick and there is no calcification located on the leaflet or the annulus. So this is the annulus here. The patient is annulus level is 28.5, and from the IVOT you can see this is 31 millimeters, and ascending aorta is 34 millimeters. So the main anchoring area is annulus level. We used multiplanar analysis. Now you can see every 2 millimeters above or below the annulus. It's almost around 28. Yeah. So we did MAC, and Matthias, I know the all-in-one technique, right? We use vata flow 30. So severe regurgitation. This is a coronary. Coronary is good. And we use vata flow 30. Now you can see we actually we need some tips. We need to push the wire, and also we give some pressure, to the delivery system to make it more coaxial, and 180 pacing during the procedure, and then we release the valve. Now you can see always we put it a very high position. So this is the reason why we have a lower risk of pacemaker. So this is another case, 84 patients. This is also a big sinus and also big annulus. This is a CT imaging. The annulus is 28, the LVOT is better than the last one, and the STG is also good. But ascending aorta a little bit, dilated. So this is a multi analysis. You can see almost 28. Okay, so we check the position. So this one is even better because ascending aorta is more friendly, compared with the last one. So this is the final results. Okay. This is a third case. Okay. The third one, I think, is another valve. So I think, with this method, we can screening, for the right candidates, for the pure AR patients to use the TAVR valve, especially the Vita flow. With the tubular self-expanding valve, we can have a good device success, and also we have, less pacemaker raise. But I think in the future, we need a special valve, to treat aortic regurgitation. This is a third case. And, in China, we started to use the new type of TAVR valve, like the Jena valve in Europe. So this is Jena valve patients. The annulus level is 26. LVOT is 26. Ascending aorta is good. Actually, this is a type 1 patients. Now you can see with the Jena valve, actually, we don't need to be any nervous during the procedure. So we release the anchor. We adjust the delivery system. This is an adjustable delivery system. And we rotate, the anchoring. Then we check, we push the whole system in to the sinus. And we check in every sinus. And then we deploy. Actually, this is a 10 minutes procedure. Yeah. I did the live case on Thursday this week. It's only 10 minutes procedure. Yeah. I think this is the future, but before the Jena valve or the Taurus Trio valve from Beijing company to be commercial, I think we still need to use AURORA classification and to screen, which patients is good candidates, and also to use the tubular-like self-expanding valve to treat this kind of patients. Actually, we will have a good results. In summary, the transfemoral TAVR for aortic regurgitation is challenging and associated with poor outcomes. And the new TAVR-directed AR morphology classification give us a new guideline, to identify anatomically suitable patients. And we have AURORA study for 69 patients from 19 Chinese centers are now included. This ongoing study demonstrated, the transfemoral TAVR using tubular-like self-expanding device can reach excellent clinical outcomes in suitable AR patients by the new TAVR-directed AR morphology classification. Thank you.